Connected by purpose, driven by passion. This is Children's Healthcare Canada's Spark Live webinar series.
Children's Healthcare Canada would like to thank our Keystone funding partners for their ongoing contributions that support all of our programs and activities, including this Spark Live weekly webinar series. Spark Live is where we gather each week to curate, convene, and showcase excellence and innovation from across the child and youth healthcare community. Our goal is to spark conversation, ideas, and action. There are two options to join in on the live conversation. Questions and comments for our panel or presenters can be typed into the question box, or comments that you want to share with the audience can be typed into the chat box and be visible to all of the attendees. For those of you on Twitter, tag @ChildHealthCan on any webinar-related tweets or use the hashtag SparkLive. And to keep up to date on all of Children's Healthcare Canada's webinars and other activities, be sure to sign up for our weekly Spark Bulletin by visiting our website at childhealthcan.ca.
Hello everyone, and welcome to another edition of Children's Healthcare Canada's Spark Live webinar series. I'm Paula Robeson, your host for the next hour. Children's Healthcare Canada acknowledges that our offices located in Ottawa are on the unceded, unsurrendered territory of the Algonquin Anishinaabe people. We are grateful to be and live on this land. As well, we recognize that our participants in the webinar today are attending this session from traditional Indigenous lands across what we now know as Canada. Please take a moment to make your own land acknowledgement to the peoples of those lands, thereby actively participating in reconciliation as we navigate our time in this session, learning and supporting each other. Today, we're delighted to partner with Solutions for Kids in Pain, or SKIP, to bring you the Canadian Pain Task Force, Best Practice Findings in Pediatric Pain. Just a reminder that this session is being recorded, and as mentioned in the intro video, please type your questions into the question box at any time. I'll prompt you via the chat as well. Fiona will pose the questions to our panel at the end of the session. I'd like to introduce our moderator for today, Dr. Fiona Campbell. Fiona is the co-chair of the Canadian Pain Task Force, as well as the hub lead for SKIP's central hub located at Sick Kids in Toronto. Fiona will introduce the panel. And it's my pleasure to now pass the mic to Fiona.
Thank you so much, Paula. As moderator, I would like to extend everyone a very warm welcome and also thank you for joining today's SKIP and Children's Healthcare Canada Spark Live webinar. You can see the title on the slide in front of you. On behalf of the Canadian Pain Task Force, our Health Canada dedicated secretariat, kids and youth with lived experience of pain, and Solutions for Kids in Pain, or SKIP, we are absolutely delighted to be here today to present our work that shares the common goal of reducing the burden of pain for children and youth living in Canada. Next slide, please. For those who don't know me, I have the great honor of being co-chair of the Canadian Pain Task Force, but also to add that my day job is as a pediatric pain anesthesiologist, and so this webinar is very close to my heart. Today, it gives me great pleasure to introduce three speakers and an additional panelist. Our intros are brief. Our speakers are all very interesting people. You can find their full bios on the registration link. I encourage you to read them. I'm going to introduce all of the speakers now, but we will go through their presentations sequentially and then, as already mentioned, take questions at the end. First up, we will hear from Dr. Michael Sangster, who will provide an overview of the Canadian Pain Task Force with focus on phase 2 report findings as they pertain to pediatrics. Mike is a pediatric physiotherapist and clinical specialist in pain science. He is a professional practice leader for physiotherapy and works on the complex pain team at the IWK Health Center. He is an adjunct faculty member at the Dalhousie University School of Physiotherapy. Secondly, we will hear from Catherine Dibb, who will provide patient partner reflections and discussion with a focus on her role and contributions to the work of the task force. Catherine has lived and living experience of pain and also now works as a patient engagement coordinator at Solutions for Kids in Pain, where she matches patient partners with exciting projects and initiatives to help improve pain management. I think Katie is very fortunate to have Catherine in this role. And thirdly, Katie Burney, who is the Assistant Scientific Director for SCIP, which we should all know by now is a national knowledge mobilization network working to improve children's pain through coordination and collaboration. Katie will talk about best practices in pediatric pain with special mention of her new SCIP virtual care and evidence gap map. Katie is a clinical psychologist and assistant professor in the Department of Anesthesiology, Perioperative and Pain Medicine at the University of Calgary. She also provides clinical care to youth living with pain and their families at Alberta Children's Hospital. And finally, while not providing a formal presentation, I would like to introduce Andrew Taylor, who leads the Secretariat at Health Canada that supports the work of the task force, and arguably the glue that holds us together. Andrew is here to participate in the panel discussion to answer questions you may have about government engagement with our work. None of us has any disclosures relevant to the presentations today, so it is my very great pleasure to hand it over and take it away, Mike. Mike, you may be on mute.
Yeah, yep. No, I'm just getting accustomed to the technology. Thank you very much, Fiona, for the wonderful introductions and kicking us off. As Fiona mentioned, my role for the next 15 minutes or so is to really provide an overview of the Canadian Pain Task Force, its mandate, and our Phase 1, Phase 2 activities, with a particular emphasis on the findings of the second report, and a particular emphasis in that on the impact of COVID-19 and how this all relates to pediatric pain in the children's healthcare community. We know that for years we've had a number of strong advocates, including people living with pain, healthcare professionals, researchers, policymakers, and non-governmental organizations contributing to a movement for action, so to speak, on the management of chronic pain in Canada. We also know that we've had innovative clinical models, proven educational approaches, novel support programs across our country, and also we have world-renowned research that exists in Canada, in particular in the area of pediatric pain. And what we need now, and what has been recognized, widely recognized, is a way of bringing this together, a way to amplify our efforts, to coordinate our efforts, and that is through national policy and through access to resource, so that we can really accelerate our work and address the current gaps that exist and the inequities that exist. And to that end, the Government of Canada made a formal commitment by creating the Canadian Pain Task Force in March 2019 in an effort to better understand and address the needs of people living with chronic pain. The Canadian Pain Task Force is comprised of 8 members and includes people from a broad range of disciplines, a broad range of experience and expertise, including people who are personally impacted by chronic pain, Indigenous peoples, researchers, educators, and health professionals, and also across major disciplines that are involved in the assessment and management of chronic pain. To support the task force, there's a 16-member external advisory panel. And the external advisory panel follows suit in that they have wide and broad representation as well, and wide geographic representation, so that we are truly covering our great country. The external advisory panel is really serves the task force in the sense of providing up-to-date scientific information and evidence and providing advice on task force activities. The task force and the external advisory panel are further supported by the Secretariat at Health Canada, and the Secretariat engages with a federal, provincial, and territorial working group on pain and a working group comprised of several federal government departments, this interdepartmental working group on pain. So lots of opportunity for sharing of information and advice as we move forward in the work. The task force was given a broad 3-year mandate, really focusing on three things. Firstly, to assess how chronic pain is currently addressed in Canada. And this was the composition of the Phase 1 report, which I'll get to momentarily. Secondly, to conduct national consultations and to review the best available evidence so that we could identify best practice, leading practice, potential areas for improvement, and the elements of an improved approach to the prevention and management of chronic pain in Canada. And finally, the task force is to collaborate with key stakeholders, including the chronic pain community, federal, provincial, and territorial governments, health professionals, researchers, Indigenous populations, in order to disseminate information related to this best practice of the prevention and management of chronic pain, and with a special emphasis on populations that are disproportionately affected by chronic pain. In June 2019, the task force submitted their first report entitled Chronic Pain in Canada, Laying a Foundation for Action. And this was really an assessment of how chronic pain is currently addressed in Canada. And the report highlighted gaps in access to timely and appropriate multimodal care, gaps in chronic pain surveillance and health system quality monitoring, gaps in education and in training and awareness for individuals and healthcare providers, and gaps in research and related infrastructure. It also had some specific findings related to children and adolescents. And we see that chronic pain is indeed common among children and adolescents, with a prevalence ranging from 11 to 38%. Common presentations including recurrent headaches, abdominal pain, back pain, and musculoskeletal pain. And what's interesting in this age group is that pain is occurring within the context of a developmental trajectory. And we know that pain in childhood or adolescent can lead to chronic pain in adulthood, substance use, and psychological disorders. Phase 2 was completed between June 2019 and August 2020, and this was 2020, and this was this national consultation and evidence-based review to look at the identification of best and leading practices, potential areas for improvement, and elements of an improved approach, as I mentioned earlier. And as a part of this engagement process, we undertook an extensive series of consultations. And this constituted regional workshops where we had participation from young adults living with chronic pain and their partners or their carers so that they could share their experience about things like transition from pediatric care to adult care. We also had a wide range of pediatric researchers and clinicians as a part of our consultation process. Additionally, we had an online consultation process where we had 4% of respondents as young adults. And we had specialized discussions with a focus on pediatric populations, including with organizations such as SKIP, which you'll hear about a little bit later in the webinar. The task force also completed a number of evidence reviews and analyses, included rapid reviews on preventing transition from acute to chronic pain, managing pain, mental illness, problematic substance use, economic costing, both indirect and direct costs of chronic pain, and scans on population-based disparities and disadvantages, and also with a focus on COVID-19. What did we hear? What did we learn? We submitted in October 20 this second report, and it was entitled Working Together to Better Understand, Prevent, and Manage Chronic Pain, a What We Heard report. And that really yielded 5 key thematic areas for us, 5 key themes that we wanted to move forward with. The first being access to timely and patient-centered pain care. We heard from participants about the importance of flexible models of care based on need, extending pain management care to children, teens, and their families in their communities and during care transitions, and improving access through virtual care models, such as what we see at Sick Kids. So Sick Kids is a great example of mobilizing to virtual care in our COVID times. And feedback from families and patients indicate a 72% preference for virtual care, and 84% of respondents felt that virtual care saved time and money and didn't compromise the management of their chronic pain. So certainly suggesting a significant opportunity for us as we move forward. Secondly, we one of the thematic areas was awareness, education, and specialized training for pain. And we did hear in a pediatric context about pain being a major priority in certain hospitals, like Alberta Children's and Sick Kids, as evidenced by their pursuit of Childkind International designation. And Childkind is an organization that merits institutions with a credential, if you will, for their best practice pain management. So what's interesting in our consultations is that participants called for institutional accreditations such as Childkind tailored to adults, which could be used across the country. There also was a finding that participants were looking for the education of children and teens at the school level in order to promote the benefits of an active lifestyle and educating the public about basic and preventative strategies for pain to mitigate the potential need for pharmacological interventions in the future. The third thematic area was pain research and related infrastructure, and we heard that there's a need for a better understanding of the unique care for children and how to better tailor and target care to their needs and experiences. So examples cited by participants included things like clinics that are integrated with academic institutions, such as the Stollery Children's Hospital being connected to the University of Alberta, or the Centre for Pediatric Pain Research at the IDBK Health Centre being affiliated with Dalhousie University. We also heard of the value of programs such as Solutions for Kids in Pain, which is a newly formed knowledge mobilization network based at Dalhousie University and co-led by Children's Healthcare Canada that seeks to really bridge the gap between the current treatment practices and available evidence-based solutions for children's pain in Canadian health institutions. Our fourth theme was monitoring population health and health system quality. And we really heard about the limitation in data regarding pain in children and youth and the need for further research in this area, given the health and economic implications of chronic pain over the lifespan. And finally, the fifth thematic area was a focus on Indigenous peoples. And we learned about the negative experiences facing many Indigenous peoples living with chronic pain when navigating a health system that contains bias and racism and privilege. Participants expressed concern about emotional pain that results from Indigenous children and youth being removed from their homes, the turbulent navigation of the foster care system and loss of identity, and the history of the residential school system. But we also heard of opportunities where participants noted the work of the Aboriginal Children's Hurt and Healing Initiative at Dalhousie University, which works with Indigenous communities, health centers, and clinicians to bridge the gap in the understanding of Indigenous children's pain. We also focused in on the impact of COVID-19 because that seems to be the theme of the day in all things that we're currently experiencing. And we really heard about the health system's inability to effectively manage pain being further exacerbated by COVID-19, given the related public health restrictions. So for many people living in pain, COVID-19 increases stress, mental illness, disability, and use of substances and medications, as well as reducing access to services and procedures. We also heard that of increases in chronic pain potentially as newly triggered acute pain goes unmanaged, how existing chronic pain could be exacerbated, and how chronic pain could potentially develop as a result of COVID-19 infection. But again, in the spirit of opportunity, we heard of responses to the pandemic holding great promise for improving pain care and aligning with best practices that are emerging from the work that the Canadian Pain Task Force is doing. To that end, when we look at the innovations, the system innovations that hold promise, we certainly see that things like rapid mobilization of virtual care, centralized multidisciplinary assessment and intake, stepped care platforms are all things that hold great promise for improving pain care. Centralized intake and triage, for example, provides the potential for a great reduction of wait times, improving patient experience, bringing together services, allowing for rapid access clinics, providing education and self-management resources and support immediately upon referral when they could potentially be most useful. Stepped care models are commonly seen in mental health care and now being used in pain management and can help facilitate the navigation of wait lists and facilitate rapid access to services and resources post-COVID-19. Also, enhanced self-management tools and resources. So providing patients with the tools and the support that they need when they need it, decreasing the burden on what will be a recuperating healthcare system. And finally, as we've spoken of earlier, the virtual care models that work to improve access. And we know that patient evaluation and including physical assessment can largely be done virtually, but virtual pain care is still underutilized. But we do see very successful models, as mentioned earlier, with the Sick Kids Chronic Pain Clinic. So where are we headed? Where are we moving forward from here? We're moving into phase 3 of the task force mandate. And really moving forward, we have multiple goals, and we're focusing on continuing to engage our stakeholders to try to leverage the work we've done to enable and facilitate change and build awareness around options for improving approaches to pain management in Canada. And our final report will outline the needed actions to improve the understanding, prevention, and management of pain in Canada and prioritize our next steps for decision makers across the country. So with that, I'm going to stop and I'm going to hand this over to Catherine. I've known Catherine for a long time, and she's going to talk to us about her lived experience with pain.
Okay, there. Hopefully everyone can hear me. Thank you so much, Mike. I said this in the prep that we had for this presentation. Mike was actually my physiotherapist at the IWK, and he was absolutely amazing. So this is very much a full circle moment to be able to talk today with him. So that's very exciting. And I'm also just in general very happy to share my experience living with pain in order to try to improve pain care. So these types of discussions like this, I think, are amazing, and I'm very happy to be here. So I just wanted to give a little bit of background and share my story a little bit before going into my experience at the Atlantic Regional Workshop, and then also just give my perspective on the second report. So I've had chronic pain since the age of 15. I'm now 24. And I still live with chronic pain, and it's from a car accident, and it resulted in extreme intense pain in my back, neck, and also persistent headaches. And it's been very, very difficult and a long journey, but there's been a lot of amazing people that have helped me along the way. So I really hope that the work of the task force can help more people find those amazing people and find those solutions. So I just want to get into, I guess, my experience at the regional workshop. So I was very excited when I heard about the task force. I think for a lot of people in pain, this felt like a huge win to have the government recognize chronic pain as a very real and significant health concern. I think for a lot of people, this felt very promising and very exciting. And then also to have it be led by Fiona, who's absolutely amazing, felt like this was going to have a huge impact. So I was very excited when I had first learned about it. And then to be asked by Andrew to come to the workshop in Halifax, I was very excited to be able to have the opportunity to hear from the people of the task force, and then also to have the separate discussions that would go into the second report. So the day was honestly amazing. I think that it was done so well, and it's hard to believe that so many of those were done across the country. It was super well organized. We heard from a lot of amazing people on the task force, so it was nice to have the presentations to sort of get invested and hear the mission behind it and how it came to be. And then I also got to hear from fellow patient partners on the task force. Linda is someone who stands out in my mind. She was from New Brunswick, and she did an absolutely amazing job when speaking about it. And then we also had the discussions with our tables. And one thing that I noticed about my table, and I would imagine all the other tables were the same, was just the amount of diversity. It felt like really everyone that was invited, there was a lot of thought gone into it, which I thought was awesome. There was a lot of diversity in age and race and the provinces where people were from. There was people from not only from Halifax, but from Newfoundland, New Brunswick, making sure that they really got people from across the Atlantic. So that was amazing. And then, I just thought that the discussion was really great. And there's a particular experience that I had when speaking to everyone that really stuck out in my mind, which was the moderator at our table, Bias. He was amazing. He works for the task force, and he was writing down everyone's thoughts into this document. And I remember at one point I didn't get out a thought that I had in time before the next discussion came about. And I asked him afterwards, is there any way I could just let you know what I was thinking about this? I really wanted to get it out, but I didn't have time. And he was like, oh, of course. And he wrote down exactly what I had said. And I saw that he wrote it down. And that particular experience meant so much to me, because I really felt like, one, he was listening, that it was being recorded, and that just because that session sort of had ended, it didn't mean that my experience didn't matter and that my opinions didn't matter. So that was a really big thing that stuck out in my mind. So I'm very appreciative to him for that. And then when I saw the second report, I really had that feeling of, wow, I do think that every single voice was heard. I felt like a lot of the report reflected things that we had talked about that day, which I think is cool when you think about this being one workshop, one person, and this being done pretty much across the country. And for me to feel like my perspective was reflected in the second report, I think is very cool. So one thing that I really noticed in the report is, like Mike had said, to the access to timely patient-centered care, which I thought was very appropriate to say timely, because a big discussion that we had was just that a lot of people really have the runaround before they finally get a diagnosis and finally get any sort of access to pain care. So for everyone, I think it's a little bit different. For me, I was lucky because I made it to the IWK pain clinic in less than a year. But I think for a lot of people, it can be a lot longer. But it was still very difficult along the way, because in that time frame where you don't know what's happening, no one can tell you why you're having persistent pain. It's very scary. You're normally not getting very good pain care, if any at all. I remember I saw a sports medicine specialist, and he told me I was fine and to take Tylenol. And I think especially for young people, I don't know why, but a lot of people can sometimes think that young people are just faking it and they don't want to go to school and they're exaggerating, and especially that teenage age, which I think is really, really upsetting. So I thought that was a great thing that was talked about in the second report. Just having longer wait times and making sure that finally when people get to someone's office that can help them, that they're getting what they need. And it would be great if everyone made it to those offices sooner, and if there were more of those offices. So if we could have more physicians like Fiona, more practitioners like Mike and like Katie, who really understand pain and can help people, that would be amazing. So the other thing that I noticed when looking at the report, and this is something that I felt a little shy to talk about, but I think that it's important, was that it does bring up financial barriers for people in pain. I think this is something that people are really scared to bring up, especially in front of doctors and people that are very educated and obviously come from better backgrounds, I guess, sometimes. But it's very, very, very costly having pain. Even when you have coverage, sometimes for me, for example, I had coverage through my mom and I was very lucky, but we still had to pay for a portion. And even that in itself was tens of thousands of dollars a year. And I know for people it can be more. And I think for a lot of people, they go without because they don't want to burden their parents or burden people in their family. And I think even past the pediatric point, when you talk about people in pain, these are often people that can't work or have a lot less capacity to work. So I'm very, very grateful for my job now with Skip because they're so amazing and very flexible with me, but that's often not the case for people. And they don't have the option to have a job where they can take time off to go to appointments, where they can take time off when they're not feeling great. And then that just perpetuates financial burden of having pain. And I think one of the solutions is really to have more multidisciplinary clinics like the one at the IWK, where you are getting therapies that might not typically be covered at the hospitals, but having physio and psych, I think we all know that they are very, very important for the management of pain. So it'd be great if more people had access to those practitioners that are very, very educated in pain and can really help people. So the other piece that I thought was really amazing is the awareness and education piece. And I liked the word awareness because I haven't seen that as much in the context of chronic pain. And I think that is really cool to think about. So we oftentimes think about educating healthcare professionals better in the area of pain. And I think that's insanely important and of course should be top of mind. And then there's been sort of this push to educating patients in pain so that they can better understand what chronic pain is. And there's lots of amazing learning opportunities that have come about for me in this push. So being able to be included in conferences and different webinars and learning initiatives, I think it can really help ease some of the questions that you have as a patient. So I think that piece is amazing. But then the extra mile I think that this report went into is just the idea of educating the general public about pain. And it would be so amazing if people felt like they understood what chronic pain really was. And when kids are going to school, their classmates aren't looking at them like, what is that? That doesn't make sense to me. Like, why would you have pain from an accident? You should be better. And it would be amazing if teachers weren't looking at kids like, I don't think kids have chronic pain. Or just different family members. It would be amazing if the general public understood chronic pain a lot better. So I think that was a really amazing thing about the report. And I just want to point out that these are things that stood out to me. Of course, I think there was so much jam-packed into the second report that I could talk about. And I think different things would stand out to different patients. But I definitely really appreciated everything that was in the second report. And I'm very appreciative to be able to speak about that today. But of course, there was lots more and I can't go over everything. So I want to give Dr. Katie Burney / my boss the opportunity to talk about, I guess, Skip's role and being able to sort of help with the education piece, and also to talk about her project that she did, which I think was amazing. And she was showing us how to use it. And I wanted to say that I actually had already used it and looked up some opportunities and some apps for headaches. So I think it could really help people. So I will leave this to Katie.
Thank you so much, Catherine, for that kind introduction. And I'll just say, I too, to everyone listening, I think the greatest accolades and congratulations to the task force. I think Catherine's comments are probably the highest compliment that can be received, which is that people who were engaged, who this impacts every day, feel like their voices were heard, and then they see that reflected into the report. So congratulations to all of those involved in the task force. So I'm really pleased to be here and excited to be here on behalf of my own research program, Partnering for Pain, and also in my role as Assistant Scientific Director for SCIP, to share what we have, which is to respond actually to some of the calls and recommendations and hopes for action in the latest report from the Canadian Pain Task Force, looking at virtual care to support youth and families with pain, mental health, and substance use. So I just wanted to put this up here too. I think Catherine really gave us some glimpse kind of into what it's like to live with chronic pain and chronic pain that begins in childhood. And this is actually a patient journey map that was co-created with Zach Jordan, who is now a young adult living with Ehlers-Danlos syndrome, and his mother, Isabel Jordan. And we mapped out together kind of what Zach's journey was as it relates to pain from when he was young as 6 years old, when he first began to experience some pain symptoms, all the way through to his recent transition into adult care. And you can see there are many, and again, this is just related to his pain experience and pain symptoms, not all of the rest that would be ongoing for him in terms of health concerns. And you can see there are many roadblocks along the way, many places where they felt they were going in circles, many places where they felt they were being abandoned by the health system, but also some successes and life that's overlaid onto this challenging journey over time. And this Isabel Jordan has partnered, and her daughter Evie, actually, who also lives with pain, have partnered with us on this project along with several other youth and parents. And I just put a quote up here as well that I think really echoes and brings to life in another way some of what Catherine mentioned and some of what is outlined in the latest task force report. The COVID-19 pandemic brought an abrupt halt to our usual access to care. Virtual care has been an option for some, but for our family, it hasn't been a smooth transition. We need to understand what's out there and how we can use it so that our kids can still access pain care even when their world has been turned upside down. And I think we're continuing to live in this space, even with the promise right now of a vaccine that's coming forward. I think also, I think Catherine really highlighted this and this collaboration, but I think we really need to shift to patient and family partnership and care. And then this is really where the game change happens in terms of how we move ahead in light years to make sure that we're identifying and addressing what matters most to the people who are living with something every day. So our Partnering for Pain research program really takes that patient and family approach to really shape pain research and care for kids together. Our work is really based around identified priorities from a national engagement priority setting partnership we conducted several years ago, of which Catherine and her mom, along with others, were part of. And from that national engagement came these top 10 priorities for pediatric chronic pain care. It's important for us to prevent acute pain from becoming chronic. I saw there was a question already about school and teachers and academic performance. And 2 of these top 10 priorities actually relate to school. So what's the impact on academic performance, educational planning, vocational planning, all of those things. What physical and psychological treatments are helpful. I think number 4 really ties to what we're talking about today particularly, which is how do we improve access and delivery and coordination of care with that view to reduce disparities. Those things are really important and already highlighted today. What strategies effectively increase healthcare provider communication, understanding, awareness? Catherine mentions stigma. What strategies effectively increase government and organizational financial support for evidence-based chronic pain care for youth? How do we educate school personnel that chronic pain is real in kids, that it has an impact, and how to treat it? How do we best manage acute pain flares? What about chronic pain and mental health when they co-occur? And when are treatments most effective? And I think a lot of these overlay into the second report from the Canadian Pain Task Force, but also as we talk about virtual care and what I'm going to share with you today. So we really are trying to take action on some of these priorities together. So this project was a knowledge synthesis grant funded by the Canadian Institute of Health Research, done in partnership with SCIP, Pain BC, and the Canadian Foundation for Healthcare Improvement. And we had 2 goals. We were funded in June and over 6 months had 2 goals. One was to identify recommendations for virtual care best practices for youth with pain and their families. And the second was to identify and map out virtual care solutions into what's called an evidence and gap map to guide stakeholders, to guide youth and families, policymakers, decision makers regarding virtual stepped care solutions for youth with pain and their families to support them during the COVID pandemic, but also sustainably as we look forward to virtual care. Wasn't new, but it's certainly been accelerated and on a much wider scale. So our first step, we did a systematic review of the scientific literature to identify recommendations for virtual care. We looked at all of the scientific literature and we found 16 relevant articles that were published in the past 10 years. And here's what they told us so far. That we can leverage virtual care better. It is acceptable, it's reasonable, and it's effective, that it ensures better access to care with potential in rural, particular potential in rural and remote areas. But I think as we've seen increase in the dialogue around disparities, that there are many people who live very rurally who struggle with access to the internet still. And so it doesn't always guarantee better access to care. that virtual care previous to the COVID pandemic was underutilized. And this was especially true for how we assess symptoms in real time and areas such as psychological treatment. When considerations, best practice considerations for implementing virtual care, that they need to be freely available across multiple technologies. So this includes the phone, right? Even our old school kind of technologies are what increases access and should be used, whether it's apps or websites, texting or video conference. That this is new and needs to include some training, terms of use, and guidelines for best practice use for health professionals in the health system, but also for youth and families. That they need to use secure infrastructure, so thinking about encryption, password protection, and how authorized access occurs. That it needs to be developmentally appropriate. And by that, we're not asking a 6-year-old to sit in front of, a computer screen and sit still for an hour or an hour and a half appointment. That it must meet ethical standards of care. This is critical both for health professionals, but I think also our health system. And then it needs to be transparent in communication. Some things, including apps, for example, it can be computer generated, but look like it's coming from a therapist when actually it's just coming from computer generated messaging. So we need to be really transparent about that. How do we select best platforms for virtual care? They need to be user-friendly and acceptable to youth and families. Ideally, they're backed by some science. They're backed by some evidence that they're good, they're effective. That they should involve, ideally, youth, families, and health professionals in their development so that we know that what we're using best meets the needs of the users. That ideally, they should be individualized or customizable in some way. That they need to address, if we're going to rely exclusively or primarily on virtual care, they need to be comprehensive in terms of pain management. So when we think about this in the context of chronic pain, sometimes we talk about 3 Ps, so pharmacological strategies, psychological, and physical strategies. Ideally, they use multimedia content. So in addition to talking, there's also videos, text, images. They need to meet accessibility standards. We need to not just be creating this and selecting virtual care platforms that work for people who speak verbally, who have eyesight, clear eyesight, and who can hear. We need to be thinking about that accessibility. And that they ideally can also integrate social and peer support. But there are lots of gaps that were already identified pre-COVID as well. We need required standardized practice guidelines for implementation of virtual care, but also evaluation. How do we find out if it's working, if it's helpful? We need to make sure we have evidence that shows that care can be delivered virtually effectively to address all of the concerns identified by youth and families. We need to know more about its limitations and suitability for all aspects of care, particularly in the context of a physical exam or physical assessment. We need to consider potential harms or potential impact on the therapeutic relationship. What is it like when you're meeting your healthcare professional for the first time virtually or in emergency context when we don't, you don't have that foundation of that in-person kind of relationship that's been established over time? That with virtual care, we need to think about strategies that enhance engagement. Think about use of apps. There are many apps that are created that never get used or that get used once and never get picked up again. So how do we encourage and enhance engagement in their use? And I think critically, as we think about sustainability with virtual care, how does virtual care integrate into clinical care pathways? How does it interface with face-to-face care? Face-to-face care does need to happen at times. So how are we deciding when a virtual appointment versus a face-to-face appointment, and having that based on health decisions, not just on infection or COVID restrictions and considerations? And how are we integrating some of this with the electronic medical record? So those are kind of overall, and you'll see many of these are not specific to pain, right? I think a lot of these are relevant to virtual care in general and considerations of virtual care with youth in child health or across the lifespan. I wanted to briefly introduce, as I move into phase 2 of our project of mapping out solutions, this mention of stepped care that Mike also talked about that's in the new task force report. And essentially, stepped care is identifying ensuring that individuals are getting the right care that meets their individual level of need, and that level of care can be flexed up or down depending on the needs of the person with lived experience or the patient and family. So for the purposes of our project, we mapped across 5 levels of stepped care. And I will say stepped care is not new. It's a model that's been used in other areas of health. And you'll see this was adapted actually from the Mental Health Commission of Canada as a project of an e-mental health demonstration project in Newfoundland and Labrador. So the lower levels of stepped care being something that's self-guided, such as apps or websites, a low level of need, something that could be relevant for the whole population, moving up to peer-to-peer support, then starting to see more minimal health professional involvement. So this could be, a real-time, one-time workshop or a health professional assisted e-supports. So not in real time, kind of through an app or a website. Moving up to ongoing real-time health professional interaction. So this could be an ongoing virtual group or virtual individual therapy. And then that highest level being real-time specialist health professional engagement, such as a tertiary interdisciplinary care that's happening over video conference. And you'll see as you move up, more resources are required and greater time commitment is involved. So the second phase of our project was to map out and identify virtual care solutions across the stepped care continuum. And we looked at 3 sources of information in creating our evidence and gap map. One was looking at the scientific literature. So what apps, websites, virtual treatments, virtual groups, virtual clinics exist. So there's 105 articles that or abstracts that show up in the evidence and gap map. We looked at the app stores for iOS and for Android for pain apps that were relevant for kids. And we also looked at interactive websites. And so you can see there were a number of those. And then in partnership with SKIP and with the Canadian Foundation for Healthcare Improvement, we put out a call for innovations in virtual care, recognizing that since the pandemic and since this rapid pivot to virtual care, it was quite likely that new innovations had emerged to fill a space in our critical level of need. So through that call, it went through the summer and ended in September. 8 established and emerging innovations were identified, and those are also integrated into the evidence and gap map itself. So I'm just going to show a brief video that I think will introduce the evidence and gap map before I show it to you.
Right now, 1 in 5 children are living with chronic pain. That pain comes in many forms, like headaches, stomach aches, and muscle pain, and is one of the most common symptoms experienced by youth during stressful events, like the COVID-19 pandemic. Treating these symptoms now is key to preventing a lifetime of chronic pain, mental health, and substance use problems. Families already had trouble accessing care, and the pandemic has only made it more difficult for children to get the care they need at traditional health centers. There has never been a more urgent time to understand and use virtual care. Virtual care offers the opportunity to connect with a health professional or peer support group via phone, text, video conferencing, and other apps right from the comfort of your own home. And while there is work to do to improve internet speeds and connections in rural communities, virtual care makes healthcare more accessible for so many more people. This style of care is new, but we already know it works. Things are changing every day, and we're in a constant state of information overload. But good, reliable information is available from trustworthy sources across the country and around the world. We want to make it easy for people to find and use that information now. So we created this evidence and gap map as a centralized one-stop shop for patients, parents, health professionals, and policymakers. The map combines all of the evidence on virtual care interventions from around the world and displays it in a way that quickly highlights what we know and what we don't know. Interventions can be filtered by the quality of the evidence or what technology they use. You can see what's new, what tools each intervention offers, and who it's designed for. This map is a guiding light for people working to establish and pursue innovative ways to help youth living with chronic pain today, in the hopes they can get back to living life pain-free. This is new. It is working, and we need it now more than ever. To explore the virtual care evidence and gap map, visit partneringforpain.com.
So this is what it looks like. And actually, I'm going to switch my screen to go online to show you how it works in real time. Oops. So if you go on to, this is what our interactive evidence and gap map looks like that you can link to through the website. And you'll see it's mapped out. Each row is the levels of stepped care that I introduced you to. And then across the top is different components of virtual care for which this has been mapped. And these components for virtual care were determined through a patient and parent advisory group, as well as knowledge of health professionals and chronic pain literature. So you can expand each of them to look at different symptoms of care, symptom tracking, medications, and so on, psychological strategies, physical strategies. And each of the colors represents different levels of the quality of the evidence. So the red is critically low, yellow is low quality, blue is moderate, and 6 is high quality. And the size of each of the bubbles reflects the number or amount of literature within this. So there's lots you can expand. I saw one of the questions, you can filter it by the different qualities of the evidence, the technology platform it uses, and who it's designed for. And you can start to see it change. And I just, given the Q&A in there, I thought I'd look at the school resources. So you can see, there are some resources for self-guided. So these would be apps or websites or other things like that that speak to school accommodations or provide evidence for virtual school accommodations, and then information for teachers. And if I wanted to click on one of those, it opens up this information box on the side that actually tells me what the resource is. So in this case, it's a scientific article called Managing Chronic Pain in the Classroom, Development and Usability Testing of an eHealth Educational Intervention for Educators. And you can see more information about where to find that resource or article in this scientific article, in that case, who it's by, and so on. And it will change depending on the filter. So I'll just give you an example. If we wanted to only look at high quality evidence, we can update the map and start to see what it looks like. So feel free to check it out based on your kind of individual needs and resources and interests. So what are some of the takeaways? There's a lot of evidence for virtual care across chronic pain conditions and for youth. There are tons of apps. Apps report the most customizability. Psychological strategies are reasonably numerous and actually overall have the highest quality of evidence. But there are tons of gaps. So most of the apps and websites lack scientific evidence. They're critically low or low quality. There's a lot of lack of information at higher levels of stepped care. So that's specialist care or ongoing care from health professionals. Things were rarely integrated into the electronic medical record or ability to communicate with healthcare professionals. And only a moderate number engaged parents or provided very little peer or sibling support. And many did not identify areas that were important to patients and families. So addressing medication side effects, medication tracking, sleep, diet, substance use, school resources, information for teachers, and dealing with acute pain flares or other crises such as suicidality. And very few addressed web content accessibility. So lots of room to go. And I'll just also mention, we're doing some ongoing work to engage with Black youth living with painful sickle cell disease, Indigenous youth with chronic pain, and youth with medical complexities in their families about how do we ensure that those best practices for virtual care do actually reduce disparities in care and are inclusive. And then there's under development, led by Dr. Jen Stinson and Melanie Knoll, integration of some of the evidence from the evidence and gap map into creation of a virtual stepped care kids pain portal integrated in partnership with Wellness Together Canada, which is a virtual stepped care model for mental health. So I will leave it there, and just thanks to everyone who's been part of that project team. Thank you.
So thank you so much, Katie, and also to Mike, Catherine, for sharing your perspectives and work, which I hope is bringing hope to over 1 million kids living with pain in Canada. I was particularly touched by Catherine's comments about how she felt heard and saw the voices of people with lived experience reflected in our second report. It is great to see so many interesting people in the audience, including international colleagues from Brazil and India. And there are some great comments and questions in the chat. But before getting to your questions, I might take moderator privilege and pose the first question to Andrew, who leads the Task Force Secretariat, to ask him to comment a little bit on the federal connections that have been made in government and also connections with the provinces and territorial governments. And also bearing in mind, we only have 6 minutes left, but I thought bringing you on as a panelist, it would be great to hear a little bit about that.
Yeah, thanks, Fiona. And I'll go through it quickly. And if anybody's interested in learning more, feel free to contact me. But in addition to having the task force, as Mike talked about in his slides, we also have an interdepartmental working group where outside of various groups in Health Canada, but then also various groups at the federal level outside of Health Canada have sort of come together to form a bit of a working group where we can better understand federal actions related to pain. There's quite a few actions in different kinds of areas. Veterans Affairs, Indigenous Services Canada, StatsCan, the Public Health Agency, all of these groups are sort of come together to think about how we can better look at and put forward strategies for pain. And then, of course, in the work of the task force, it was really important for us to get a sense of what was going on in all the provinces and territories who really have control of health system delivery in Canada. And it was through those initial consultations that we saw a great willingness amongst the provinces and territories to come together to better collaborate and understand best practices and issues across the borders. And so we also have an informal working group with representatives from all of the provinces and territories looking at better connecting common work related to understanding best practices, looking at pathways to care, looking at developing research networks and having better coordination. And so that work kind of exists in the backdrop of the task force, and the task force also helps to promote it and move it forward. And so just acknowledging that that lots of different government departments have come together, and there's much interest across provinces and territories to figure out how to address these issues as well, although some are further along than others.
Thank you so much for that, Andrew. Excuse me, I'm going to turn it over to the questions coming up in the chat. We had a couple in the Q&A. One was about schools, and Catherine did a great job answering about what she would like to see in schools. And Katie also brought that up very nicely in her presentation. So I think that one has been dealt with. There was also a question about engagement of people with disabilities, and I think Katie really spoke to that already. There are some unanswered questions here in our remaining few minutes. One is, what do you think about physical interventions, say exercises, physical activity via virtual care for youth with chronic pain? Is there space for it, such as with psychological intervention? So maybe I'll turn that one to Mike.
Thanks, Fiona. So I think the answer is absolutely yes. Really, in working with children and adolescents who are experiencing chronic pain, the goal of the physical therapist in that is the goal of the child and adolescent. So we find ourselves, rather than in the management of an acute injury kind of model where there might be a little more specificity in the exercise we prescribe, we find ourselves in the chronic pain space in more of a coaching sort of model. So it works really nicely via a virtual platform to be able to offer that. So it's really about understanding what it is that is important to the youth, the child, youth, or adolescent, and providing them intervention in a goal-directed way. So really responding to their needs, their goals in a coaching type format.
Thank you so much, Mike. One of the questions in the chat were, what are ways we can get involved? And there are lots of ways to get involved. I mean, I've put in the contact details for the Secretariat, but also if you're a patient partner, you could reach out to Catherine and Katie. There's always opportunities, partnering research opportunities, helping us raise awareness as we develop interventions for schools and so on. So please do reach out to us. I want people to think about the 4 buckets that we have in terms of access to care, better awareness and education, improved research, and monitoring and surveillance. Those are kind of useful buckets to think of when we think about how to improve pain care in Canada. And so if you have any questions or comments on thoughts about any of those areas, do let the Secretariat know. There's always room for innovative ideas from people such as yourselves. Yeah, Catherine has actually put the contact details for the patient partners. So if anyone wants to get involved from that perspective, that's been helpfully placed in the chat as well. The other thing I was going to say is that for anyone who has unanswered questions or who thinks of things afterwards that they want to ask, please do contact any of us. And also Paula has said if there are unanswered questions, we will endeavor to provide responses when the webinar recording goes live. And so I think, Paul, I'm looking at the time. I think we're kind of out. And I really thank the panelists again for tremendous presentations and for the engagement of the audience. And so over to you, Paula.
Yes, it does look like we're at the end of our time today. I want to thank you, Fiona, Michael, Catherine, Katie, and Andrew for sharing your time and expertise with us. Most appreciated. Thanks to all our members and other attendees for spending this time with us. We hope you depart with some practical knowledge to bring back to your organization. This webinar marks the end of our packed fall Spark Live webinar season. Join us on January 13th for the start of our winter Spark Live season, when we'll be partnering with CIHR to bring you the findings and implications from child health research projects funded through CIHR's COVID Mental Health Knowledge Syntheses Grant. And we'll be bringing those to you on January 13th and 20th at 11 a.m. Eastern. As well, we're looking for additional content to complete our Spark webinar series for the winter. If you have an innovation or improvement story you want to share or are ready to spread and scale your initiative, please contact us at spark@childhealthcan.ca. And on January 26th and 27th, Children's Healthcare Canada is pleased to host the first Canadian Transitions pop-up event. Please visit childrenshealthcarecanada.ca for more information to register. It's always great if you can watch live, as your questions and comments really enrich the discussion. But if you can't, the recordings of these sessions are made available after the fact on our Knowledge Exchange Network. So thanks again for joining us today. Thanks to Fiona, Michael, Catherine, Katie, and Andrew for this presentation, and to Skip for supporting our webinar program. And hopefully we'll see many of you back here in the new year. Bye, everyone.